So she's a 41-year-old female. I'll withhold rest of the history. This is her MRI, arterial phase. Just get rid of these. And this is the portovenous phase. Maybe there's some more findings. So any thoughts on what this could be? Differentials that we may consider?
Ben says adenomas, yes. Is she on
FNHs.
FNHs?
Okay, and that's the diffusion.
Not FNHs.
Not FNH.
Yeah. And too many lesions on the diffusions, too many more than.
Mets.
Then this is the PET. And this is the MRI after she was given some treatment for whatever she had.
Gitanjali, was that a PET, like a FDG PET or a dotatate PET?
FDG PET.
Oh, because I was thinking maybe neuroendocrine, but and then she has like that FDG avid thing in her left lower quadrant. Like, is that a colon cancer? Or... Oh, what's a bone met?
Yeah, that's a bone lesion. So multiple bone lesions, and then these lesions in the liver.
And it doesn't look like she has a breast mass.
Yeah, the age might be a distractor, younger patient, but I mean, now this is seen across all age groups, but more commonly we see it in older age groups. So the history was multiple myeloma. So this was, these are multiple myeloma lesions, and this was extramedullary disease. This is how it commonly manifests as uniformly arterially enhancing lesions in the liver, which wash out, but they still retain some contrast. And the reason I was showing this case, because I showed that case last time, which was an HCC in a patient with pancreatic cancer and had this liver lesion. I think I have those images here as well. And the lesion looked very similar. And the confusion in this case was this patient also had history of myeloma. So with such complex history, and you have this arterially enhancing lesion with washout, I think here I felt there was a little bit of more washout and a pseudocapsule kind of thing. So, and this patient had history of Hep C. So we favored HCC, but with myeloma, we have to be careful because it can be extramedullary disease too. But obviously because of the confusion, this was biopsy, this was HCC. And in this patient on the top, this is one of the classic manifestations of extramedullary disease in the liver. And the clue was, I mean, in most of these patients, there will be an obvious history of myeloma because extramedullary disease is more commonly diagnosed. They have known myeloma for many years. They get into remission, and a lot of them will relapse. And at the time of relapse, it can manifest as extramedullary disease. It's almost like a breakthrough phenomena where the disease starts growing out of the bone marrow independently. It responds very well to treatment, but at the same time, it often implies a bad prognosis. We have a lot of these patients. We follow these patients, and a lot of them, they usually have a lifespan of a couple months after the EMD is diagnosed. But it shows a dramatic response to treatment. It like completely disappears after treatment, but it'll come back. It'll come back. But this is a young patient, recently got diagnosed. So this patient is doing good so far, but it's just been a couple months after the diagnosis, so we'll see what happens with her. So this was the first case.
Gitanjali, I have a question. You said that this is the classic liver appearance. I didn't know that they were arterially enhancing. So that is kind of classic for myeloma. And do you know why they're so avidly enhancing?
Classic. The reason I'm saying is we see a lot of cases. I know there is nothing in literature, and that's something that our team is working on right now to see if we can write something on the imaging manifestations of extramedullary disease. But I've recently reviewed around 45 to 50 cases of proven EMD liver, and most of them show this finding that they're uniformly arterially enhancing, randomly scattered throughout the liver. Intense restriction, intense FDG avidity, and very similar to how lymphoma it looks like, because again, pathologically, these are a clump of round cell tumors, or round cells in the tumor. And I think that's the explanation why they are like arterially enhancing uniformly, and then they stay like cellular areas in the liver. Some of them have shown necrosis. Yeah, but intense arterial enhancement, even I'm probably not sure why, but very similar to how probably lymphoma will look like in liver. Like uniform enhancement, restricted diffusion, and PET avidity.
Cool, thank you.
And my next case is a quick show and tell case. I think I learned about this entity in this conference. So this is again a middle-aged female who presented with right lower extremity swelling and was found to have this big pelvic mass. So findings, and if we can give a specific diagnosis.
Gitanjali, I'm thinking maybe a leiomyosarcoma of one of those veins.
Yes, so this was a pelvic leiomyosarcoma with nice intravenous extension into the common iliac vein. So the teaching point was, I mean, this is one of the sarcomas that can, like leiomyosarcomas, they often arise from the vein wall and they can have intravenous extension. But in pelvic, the other tumors that show intravenous extension are uterine stromal tumors. So uterine leiomyosarcoma, with that also we should try to carefully look for intravenous extension, though it's not a common phenomena, but again, somewhat typical for these lesions, or more commonly seen with these lesions. And we all know that intravenous leiomyomatosis also is a known thing. So somehow all these endometrial or myometrial stromal tumors have a propensity to grow in the vein. So this was I don't know, they did not tell us whether it was arising from the vein, but the epicenter looked like it's in the pelvis posterior to the uterus. And then it started growing into the common iliac vein, and then it also extending into the femoral vein. And that was the reason for her lower extremity edema and her presentation. So yes, so if you have a tumor or sarcoma like lesion with intravenous extension, I think we can suggest that's probably a leiomyosarcoma.
Yeah, it might be arising from one of the smaller veins draining.
Smaller pelvic veins, yes. It's probably arising from one of the smaller pelvic veins and then growing in the bigger ones. Yeah. Okay, I think that's all I had.
Nice. Who wants to go next? Aarti, do you want to show yours?
Sure, let me try. Okay, you guys can see, right?
Yes.
Okay. So this patient presented with nausea and vomiting. I'll just scroll through from the top.
Looks like bowel obstruction.
Yep. So we've got all these fluid-filled dilated loops of bowel.
And then there is a
calcified mesenteric mass or node.
Yep.
Polycarcinoid.
Yeah.
And then decompressed loops distally. Yeah. So it was a complete bowel obstruction. There was this calcified mesenteric mass. So I was like, oh, this is a beautiful example of a carcinoid. It does actually have a lot of calcification for a carcinoid.
Mm.
And of course, I wouldn't just present a simple carcinoid. So
sclerosing mesenteritis.
Mesenteritis.
A good second thought. That's not what this was. And I'll show you some additional views. Oh, you can see also that there's a IUD.
Is that just a fibroid or is that a...
Yeah, so if you can see there's actually a stalk connecting it to the uterus, and I'll show you on the other views. This is the little stalk here. So this was actually a pedunculated fibroid with a lot of necrosis and ischemia, and it was causing this bowel obstruction.
like
So
TORS?
it's tethering the bowel right here. So, I mean, I think it's rare, but I thought it was cute. And also, you know, in retrospect, we could actually have suggested it because there is this stalk here. And there's another calcified fibroid. But anyway, just one that fooled us all.
Yeah. I guess because of the length of the pedicle is why it torsed maybe.
Yeah, exactly. I think so. They didn't, in the path report, they didn't say it was torse, but they said there was like extensive ischemia and necrosis. And so I think it also had like an inflammation affiliated with it that that was like tethering this adjacent bowel loop. Okay, this is my next case. So this patient presented with left lower quadrant pain. And you can see there's lots of diverticula and a lot of fat stranding and some air around it. So this was basically diverticulitis. But the cool, cute part of this case was that, you know, there was air outside of the bowel. So it looked like, you know, at least a microperforation. There wasn't a walled off collection. And then there was also air tracking within this
Vein.
vein.
Yeah.
And I was trying to pull up, I found a case report about like, it was basically called like non-fatal gas within the vein associated with diverticulitis. Here we can see it tracking all the way up. I was trying to figure out exactly the cause of the gas. My theory is that it is just some of the air from the perforated diverticulitis rather than a gas forming organism, and which is why this patient actually did well with just medication. But do you guys agree with that? That it's probably just the air from the bowel loop, or?
Probably.
Yeah, if it led up to the mucosa and there was a little disruption in the mucosa, it just passively tracked back through a defect, I guess.
Yeah, that's what I'm thinking.
Yeah.
But it's also a nice example also of how you can get that septic thrombophlebitis of a vein from a diverticulitis, and then eventually that could cause like a liver abscess. Somebody is chatting in, I think.
Is there a name to this, like SMV pylophlebitis, like some name that it's known?
I don't know actually, but you know, that's interesting because pylophlebitis, I think Claude was telling me that he thinks that is specific to the portal vein.
Okay, like that's what I'm saying. Of the SMV, is there a equivalent?
Yeah. So I don't know. I would call it basically like septic phlebitis of the left colic vein or something.
Yeah.
Yeah, cool. Okay. Here's one more case.
Somebody asked if there was an associated venous thrombosis. I didn't see one, but
No, but I would still say it's like I would still call it like a septic. And actually, I did think. Yes, actually, I did think that there was, because see here, I mean, you could say like, could this be mixing? But I thought that there was associated septic thrombus here.
Yeah, the density definitely drops off. So.
Yeah, which is like not uncommon, you know, as with diverticulitis, and also like as it heads towards the liver, causing, you know, liver abscesses and stuff. Okay, this patient had a recent cholecystectomy.
wonder if the bile ducts looked so obstructed prior to that.
Yeah, no, exactly. So we have two important findings here. One, the bile ducts are obstructed, and we've got actually kind of like a clip sign. So several clips right at the hilum. And then we also have this fluid collection.
Looks like a biloma.
Yeah, exactly. So this was a biloma, and then here they left a drain in because this was a complicated cholecystectomy. And the drain isn't really in the biloma, it's like touching the corner of it. So they were concerned about biliary, and the bilirubin was like 6. So what would you do now?
Eovist.
Good idea.
Okay, so you fell into my trap. So basically, this was what the MRI looked like, and the bile duct you can see is completely, it was clipped. They actually at this point had a percutaneous biliary catheter in the bile duct. But this was the Eovist, and the Eovist never showed, we went to like 2 hours, you can see.
Maybe the liver's so pooped out, it's not excreting anymore.
Yeah, exactly. So even at 2 hours, we never got Eovist excretion. And so that's actually one of my main points here is that if the bilirubin is too high, the Eovist will not work because the bilirubin is occupying all of the OATP receptors and the Eovist won't work. So I've seen different cutoffs in the literature, and I was actually curious what you guys use as a cutoff, but we're actually starting to use a bilirubin of like 3 as like where we stop using Eovist, or like 3 to 5, we're questioning them. Above 5, we're definitely not giving Eovist because we think it won't work. But I've seen this multiple times where we're like, oh, there's a bile leak or a bile obstruction, let's get an Eovist. And especially like, even if the bili's 12 or 20, it's definitely not gonna work. What do you guys, any thoughts? Victoria, I know I've asked you this before.
I don't have a cutoff because it just doesn't come up enough for us to say, oh yeah, we got to stop doing this.
Yeah. For some reason, I think because we're a referral center where like, we get not an infrequent amount of, cholecystectomy complications, but also even just like hepatectomy, bile leaks, etc. But if the bili is too high, it's not gonna work. So,
Aarti, have you done more delayed imaging? Would that help in any way?
No, and that's another question that we've been asking is like, how long should we go? We have, when we go out to 2 hours, 3 hours, we'll take the patient off the scanner and then put a different patient on, then bring them back. But I mean, the most delayed I've seen a bile leak is like 3 to 4 hours if it's a really, really slow leak. But a bile leak still shouldn't make your bilirubin like 10, like really, really high. So that's when you're concerned about complete biliary obstruction or liver failure.
So either way, this would need some intervention, right, to decompose.
Yeah. Mm-hmm.
Yeah, nice. Even I've not thought about using bilirubins as cutoff, but that makes sense because.
Yeah, and actually, I think the Eovist manual, I looked this up before, and I think it even says like 3 or something, So first we were using like 10 as a cutoff, then 5, and now we're like, oh, like this one actually, it wasn't too high. It was like 6, and it completely didn't excrete. Okay, and then this is my last case, and actually, Roopa, this case reminds me of you and our friend Michelle. So this was a patient who got Y90 to this lesion, and this was 2 years ago. So this was post Y90, and the lesion had this kind of like raggedy border to it with all this enhancement. And then this was 1 year ago. We were calling it, first we called it, and basically there's all this like kind of nodular thickened enhancement along the edge of it. And then this is now.
How long between the first scan and the new one, Aarti?
So it was like 3 years of like 2 years ago, 1 year ago, and now.
Sometimes I wonder if the iRads shouldn't say when it's been a Y90, just to call it all indeterminate rather than, viable or non-viable.
Yeah, so first we called it possibly viable for a while. Then we started calling it equivocal. And then Michelle actually gave a great talk at SAR where she talked about post-radiation, so SBRT and Y90. You end up having a lot of this enhancement along the edge. In the long term, you can even have delayed enhancement within the lesion. And it's what she calls, what I remember as like TSEEP, which is treatment-specific expected enhancement pattern. So post-radiation, we're not going to see complete devascularization of a lesion. We're going to actually see enhancement in it because radiation kills the cells differently than a lot of, than just devascularizing it. And so they will lay down fibrosis, and we can see enhancement in it. And if it's greater than 12 months, we can just call it non-viable. We can start calling it non-viable, and that it's treatment-specific expected enhancement pattern.
Right, and in I think the next updates of LIRAD's treatment response, they've been talking about like potentially even having a separate scoring system for the radiation treated ones, SBRT and Y90 and the others, because of the confusion in nomenclature and whatnot. And then I think they'll also be looking at ancillary features a lot more, even in the post-treatment setting. So diffusion, intermediate T2 signal, hepatobiliary phase, hypointensity. So even we've had struggles where we've called it like equivocal, but then we really want to call it non-viable, but we're scared because it looks ugly because there is enhancement. But if it progressively keeps decreasing and there is no new nodular arterial enhancement, I think we can tread a little less cautiously and go ahead and call it non-viable if that 1 year is over. So
Yeah, I think
Yeah,
this is an
Roopa,
important.
I keep forgetting this term, so I always go back to that text message we sent.
TSEEP,
So I'm
yes.
writing it in here.
You have to let the T seep, steep.
So
That's
Aarti,
it.
for these cases, wouldn't like a follow-up exam help? And like if the enhancement is of the or the overall size of the lesion is continuously decreasing, and you don't see any of the enhancing areas ever increasing or change, I think I don't know if they are adding this part to their
Yeah, so
description
that's
of.
exactly the point, Gitanjali, which is that like basically our IR colleagues like weren't paying attention to our reports where we were calling it like viable. And then, one of my colleagues was like, wait, should we stop calling it viable? And I was like, yes, this is exactly what Michelle was talking about. Like we now have 2 years of stability. Like we need to just
Exactly.
call it not even equivocal, just call it non-viable.
That's what Michelle says in her talk also, right? Like a better term for these is evolving and not even equivocal.
Yes.
Like it's expected to evolve like this. So
yeah, I've been inclined to try to avoid some of the LIRADS terminology in these because I didn't just say, since treatment, there's no interval evidence of recurrent disease.
no new APHE.
Yeah, I think that's probably a better way to word it.
Yeah.
We have a similar case. I think I'll pull it for next time. But again, a young female with a large adenoma treated, and there was a lot of controversy. I mean, if we call it as non-viable, she could have gone for liver transplantation. But because of that residual enhancement, we keep calling it as equivocal. And the IR guys and liver hepatologists are stuck because they can't go ahead and do a liver transplant based on our reports.
At least in those cases, Gitanjali, if it's just an adenoma, we're not bound by the LIRADS criteria. So we can actually say what we want to.
Oh, like the adenoma that they differentiate.
Oh, it became
a well-differentiated HCC.
HCC, yeah.
This is a quick case. It was a young woman who came in, and I can't remember exactly her symptoms. It was an outside scan, but she was scanned for some sort of vague thing like abdominal pain or something or other. And she has this mass sort of adjacent to her right kidney here. So I've got T2s, some in and out of phase, and a few pre and post contrast sequences. Anybody have any thoughts? These are a little out of sync here, but the pre and post contrast, you can see it comes up sort of along the top of the kidney and then wraps around.
An exophytic AML.
We actually were also looking at this little sort of divot here in the renal cortex.
Right, Ross. Amar says, is it an exophytic AML? Two people said AML, which is exophytic.
I could support that.
Yeah, there's fat, looks like, and there's vessels going. And with that cleft, were you trying to show us like a little claw sign type?
Yeah, exactly. So, and sorry, my volume was off for a second, so I missed a little bit of the discussion,
No.
but just quickly say, yeah, you guys are probably going towards AML.
Yes, exophytic AML is what two people say.
Any other thoughts on this one?
And a retroperitoneal liposarcoma will always be a consideration.
Yeah. So we talked about this as GU tumor board, and it was basically those two things. AML, because you see that little claw sign potentially. I actually, believe me, I've been wrong many times in my life, but I actually favored liposarc here because I just haven't, and of course I've not seen everything in the world, but the AMLs I've seen, and I'd be interested to hear what other folks think, usually to me are sort of more of a round lesion that sort of maintain their own shape. And I thought this was kind of funny because it sort of insinuated along the retroperitoneum and sort of conformed to the retroperitoneal borders here. And so to me, that reminded me more of some of the liposarcomas I've seen. And we biopsied this and it turned out to be liposarcoma. And it's unclear to me if it's retroperitoneal or actually like a renal liposarcoma, but I thought it was sort of an interesting case where you might be able to suggest one versus the other based on the morphology. Does anyone else think that makes sense, or any other thoughts on that one?
Yeah, like the epicenter of it is way too much, just completely outside the kidney. And Aarti says too many vessels, notch/ice cream cone sign is more common for AML. Whereas this one looks like it's completely out, right, in the perinephric space.
Mm-hmm.
It's true. I've seen myelolipomas that are a little bit more amorphous that mimic sarcoma, and I've seen relatively few AMLs that weren't more or less circumscribed in some fashion and easier to define the borders of compared to this one.
How did this get treated, Ross?
Sorry, it hasn't been treated yet. They just got tissue. It's just very recent, so I haven't seen the follow-up yet.
Yeah, I would have thought AML because of those big vessels, and I've seen exophytic ones that are really.
Can these have MDM2 also, Aarti?
Yeah, definitely. They should, if they biopsy it, they should test for MDM2.
Maybe that's a surefire way of saying, did it come inside out or outside in?
Yeah, but I like the idea also that it might have arisen from the capsule.
Capsule, yeah.
Yeah.
Just within the perinephric. Nice.
Maybe the other thing to look for, like, shouldn't AMLs should have like some sort of an encapsulation at the periphery, whereas like this lesion, if we see laterally, just
Blends.
yeah, just fades out. Like there's no margination to it.
The way it indents the kidney is a little interesting, though. It's like it has such a broad base, but in one place it's so focally just pushing in. So yeah, it's a tricky one.
Yeah, that's sort of amorphous.
Was the demographic on the patient help at all? Like, was it?
It was a relatively young woman. I forget the exact age, and she was of Asian descent.
Does that help, Steve, in any way?
Not really. I don't know. AML, I think if the younger the patient is, the less I'm thinking it's a sarcoma.
Right.
Yeah, I think she was in her 30s or something. So she was pretty young.
So
I would have I easily gone down the tubes on this one.
I mean, we included AML or differential. Don't get me wrong. I mean, we decided that the tissue. So, I think both is.
But you were suspicious enough to push for biopsy, I guess. So.
Yeah, I mean that for sure is. That's what we told them is like we definitely cannot definitively call this an AML. Like you got to get tissue.
Yeah, and I wonder when they treat it, what they're going to do with that kidney part also, right? Like, will they take the whole?
Yeah, that's a great question because I haven't been able to follow up with the urologist since.
Yep. Let us know if you get follow-up.
I will for sure.
Yeah, thanks. Okay, does anybody else have cases? If not, I have a few.
Just one quick point about that one is that if it is a liposarc, they definitely have to resect that kidney.
Yeah.
Have to resect anything it's touching.
Yeah.
If they
because
can.
of the high rate of recurrence.
But it just it seems like overkill, right, Aarti? It's a small area of invasion, but yet they'll lose the whole kidney because of how broad the indentation is.
Yeah, but I think in this case it's worth it.
Right.
In Europe, they actually will resect like almost half of the abdomen if you have a liposarc.
And still they all come back anyway.
What'd you say?
They all still come back anyway.
Yeah. Unless you're very, very careful the first time,
Yeah. Okay, I have, let me share my screen. Okay, are you able to see my screen with a CT image? Because I lost all controls.
Yes, we can see it.
Okay, so this patient came in with epigastric pain. And so we did this CT. And that's really where the pertinent finding is.
It looks like there might be a duodenal mass.
Right. Anything more we would have said as far as characterizing the mass?
It almost looks like it's in the wall, like because you see that air displaced.
Right, like a little crescent.
Yeah, and even further down. Like that air there looks like it's luminal. So this
this is pushing it out. Yeah. Whatever it is like filling the lumen, involving the wall possibly. Yes. And then retrospective, but any thoughts on these vessels here?
Omar's saying it has a stalk.
Okay.
I was saying it could be a leiomyosarcoma or a gist. Because I like
that's kind of how I read it out too, gave those differentials. Looked a little heterogeneous, right? Like there's lower density areas and more solid looking areas. And then just now I was looking at these vessels, seemed like it was actually slightly hypervascular with some enlarged vessels coursing through the middle of the mass. So anyway, they weren't sure and they decided to do an endoscopic biopsy. And interestingly, the path came back as a duodenal paraganglioma. So it was one of those rare entities we read about and forget, but this turned out to be a duodenal paraganglioma. And in retrospect, it makes sense because of these vessels, which are really enlarged. These can have little necrosis, calcifications, hemorrhage, just like paragangliomas anywhere else. This was just a nice case of that. And just as companion cases, if there are any trainees here, this is our famous Zucker candle one, always at the bifurcation near the IMA takeoff. This one's very hypervascular, almost that swirly pattern of enhancement. And then this is another usual retroperitoneal paraganglioma. This one was kind of close to the duodenum as well, more in that portacaval region, pushing the head of the pancreas a little ahead. So few things to be careful with these. If these happen in real close proximity to the adrenal and sometimes they have fat in them, they've been mistakenly called as adenomas. Then in the case reports, you'll see if they're very close to the pancreatic head and they can potentially cause ductal obstruction and upstream atrophy, they'll get called a pancreatic neuroendocrine tumor or a pancreatic head mass. But something else to always think about in the retroperitoneum is these paragangliomas. And as I was reading about,
just that last one, the MRI one. I like that one because 30% of them will have cystic spaces, and that one has like nice cystic spaces.
It does. And that's what I was just gonna pull up. So when we look at what these paragangliomas do, we do know they all come from these chromaffin cells, and these are our popular areas. We see them head neck area. And then when they happen in the medulla of the adrenal gland, we call them PHEOs. Up to, I think 30% is a good number to remember for many things. 30 can be malignant, 30 can metastasize, 30% can be non-functional. So these are the real dangerous ones because they may not present with that hypertension, palpitations type symptoms. And malignancy supposedly is higher for the abdominal ones. The head neck ones rarely ever become malignant. Uncommon sites, I think in this conference we've shown a bladder one before, if I remember, Aarti.
Yeah, we also showed a gallbladder one.
Okay, perfect. We have two.
I remember
some
showed the gallbladder one, and then they said that it was so hypervascular that IR went and embolized it before they removed it.
Right. And then we only have to find these now, right? Like Aarti said, they can be very heterogeneous. They can have cystic areas, necrosis, calcifications. And on T2s, like we used to always teach, they have to be light bulb red. That's really not true. 30% can have low T2 signal. And that's not a necessary caveat for diagnosis. In the head and neck, we always talk about the salt and pepper appearance. This we spoke about, they can have a little fat. So be careful if it's near an adrenal and there is intralesional fat. If it's close to the pancreas, don't think it's an NET. And I just pulled up two case like literature examples. This one was a nice one, I thought, very hypervascular mass. And this one's really hard because there's upstream dilatation, atrophy, whatnot. But this ended up being a paraganglioma. And then this is something I learned about just as I was preparing for this one is we used to think only 10% of these have a familial association, but now they're saying 40% of these can actually occur as part of germline mutations. And the succinate dehydrogenase gene supposedly is the most common gene mutation, which is why if we figure out this early, these are patients who we can do surveillance on or screen them. They're autodominant. And supposedly malignancy is higher in these patients who have the mutation. There's a very nice radiographics paper from last year which talks about only these STH mutant variants of pheochromocytoma paraganglioma syndromes. So if you want to look at, and then this is the question we get asked in tumor board all the time is, how do we image these? So right now the answer is easy, it's dotatate. The detection rate is 99%. These are some of the older ways we used to do it, and you can see how each of them has limitations. But I think now the simple one to remember is dotatate. So just a little cluster of cases of paraganglioma. Yes, rule of tens is much higher, yeah. That is what I have. Does anybody else have cases?
Hey, Roopa, I want to show one companion case.
Yeah, sure. You can share screen.
So for, this is basically Gitanjali's companion case. Since we are all in the same place, can everybody see my screen?
Yeah.
So this is a case from 2013, and you can see these massive sized lesions in the liver. This is pre-T1. And then arterial phase showing heterogeneous arterial enhancement. And then this is like the portal venous phase. And so since I've already given what the diagnosis is, so this patient also had history of myeloma. And all I wanted to show was this is 4 months down the line. And pretty much all the lesions are gone.
That is scary because on the portal venous, they actually look like they even wash out, right?
Yep.
Wow.
Wow, you guys are like the myeloma treatment clinic.
Yeah.
We used to be, for sure.
What did they treat them with? I don't know much about the treatment.
It's like
there are so many regimes, Aarti.
Triple therapy it's called triple therapy. And I think Gitanjali might know more now.
No, just a combination of chemotherapy. They have this like a acronym that they use, but eventually they get stem cell transplantation.
And I mean, they used to literally scan these patients every week just to see what happened. And lesions used to just go away literally in a week. So it was very...
Wow, but then Gitanjali said a lot of them come back, right?
They do come back, yes. They do come back. It's a bad disease to have, so.
So Aarti, I'm just reading what the triple therapy was. It's bortezomib, lenalidomide, dexamethasone, 28-day cycles. And then they keep repeating it till remission is achieved and they eventually qualify for stem cell.
Cool, maybe I'm going to add myeloma to my
study list.
Extramedullary enhancing differential.
Yeah, like that one looks scary with washout and whatnot. So
yeah.
Yeah. All right, anybody else?
I'm going to share a case real quick that's not really a exciting diagnosis, but an observation. Let me.
Every time someone says observation, I think of Lyrods.
I know, right?
Well, funny you should say that because this is in the setting of HCC surveillance. But I'm just going to show you. This is the current one, which was about a month ago, and then this is the prior to that, which was at the end of last year, and it's done on the same scanner. So those are the T2s. You know, I'll click forward and show you some of the other. Here's T2 fat sat before and current. A little motion on that one. Here's some T1s. This is the out of phase. Anybody noticing anything? Post contrast. Here's arterial phase. Here's the last arterial phase. There were some LR3 type lesions. These things were, you know, now you see them during the arterial phase, and then now you don't. They were a little bit harder to see on the current one. Here's one here. But there's a difference between these two that I didn't realize until I was annoyed with the case and toward the end of interpreting it, in fact. And I was like, you know what this is? It's got some nice.
Summer's asking if the patient has gained weight.
Not really. I think it's a little bit slightly different field, but yeah,
the positioning is different now, Steve. We've lost a lot of signal anteriorly.
that's exactly right. So every sequence we've looked at, the signal anteriorly it's signal starved, like the whole front side of the thing. So the anterior coil element is basically not functioning on this exam, and so all we have is the posterior and the external.
Yep.
But everything's signal starved anteriorly. Every single sequence was the same in that regard. And when we looked into it, it wasn't a failed piece of equipment. It was just a novice technologist that didn't spot it while it was happening and probably didn't have it plugged in properly.
Yeah.
And
so will this be LIRAD's normal?
Yeah, it was a LIRAD stable LR3s, but I offered to have the patient come back, even though I thought it was probably diagnostic for what the purpose of the exam, and the patient basically declined.
Yep.
So that was my.
Amar says, cool extrahepatic observation. Yes.
Yeah. Extrahepatic, right?
Yep. Yeah. All right. I think that's all we have.
But can I show a quick companion case? Though I don't have a follow-up, I just a companion case to Ross' case. So
yeah.
You'll remember it. I think you read this one, but I just I was trying waiting for a follow-up on this case, and they never did anything to this. So that's just been sitting in the interesting cases follow-up for so long. So what would you all call this, as AML more?
Yes, AML.
AML.
Is that what I call it?
Differential for liposarcoma?
I mean, there is a difference between the two in that this one is more circumscribed, right?
Yeah, yeah.
Yeah, and it nicely like indents the kidney in multiple places and looks exophytic more, right? And you see, like you said, we see the other border of it, unlike previous case, which is blended with the
yeah, where it was just fading out in the periphery.
Yeah, to me, that's exactly what it's like. It's got a little bit of a capsule. It's more rounded. It seems to hold its shape a little better, and yeah, it doesn't just sort of disappear into the periphery. Yeah, it's a great companion case. I like this.
But unfortunately, I don't have a follow-up on this one. So
did we call this more AML, less?
Yes, yes.
Okay.
Gitanjali, in your experience, like, do you look into aneurysms? Like, do we see the aneurysmal vessels in an AML, and would you favor that over the other?
Yes, I think that's an important feature that will help determine. But again, like the vessels here are not that ectatic, dilated, where this is the arterial phase, right? Let me see if there's any other earlier phase than this.
No, but Ross's case also had vessels that were prominent though.
Yeah, so it looks like there's septal enhancement. There's some vessels coursing through, but there is really not there's one vessel which looks like which is a supplying vessel, but really not within the lesion as ectatic vessels and aneurysm formation. If that was there, then there was probably no doubt that this is an AML, but this one, I think, yeah, more likely AML because it's exophytic encapsulated, but I think I still wanted a biopsy to feel more comfortable.
How old, Gitanjali?
She is 64-year-old.
Yeah,
age. Do you have long-term follow-up? Like, do you have stability over exams?
No. These are the two back-to-back scans, like CT followed by MR. And I think after that, she was diagnosed with endometrial cancer, and then the whole focus shifted to that. And they kind of forgot about this, so she never came back for follow-up for that.
I like Ross's point about how the AMLs tend to be like more like a rounded ball kind of lesion, and the liposarcoma was kind of So that's, I think I'm going to remember that the next time.
Yes, but this is like one of the challenges that we get with these exophytic fatty lesions. Like there'll always be confusion whether these are AML versus retroperitoneal liposarcomas.
And then the other end also, right? Like the lipid poor AMLs, which are so hard to even diagnose because we end up calling them RCC,
RCCs.
or renal mass. So, huge spectrum.
Okay.